Good morning and welcome to our monthly webcast. I am Dr. Samir Mehta and this is session number 40 of our monthly webcast. Also session number 4 since our partnership with the American College of Cardiology. I am delighted this morning to have an eminent guest from Mount Sinai Medical Center. With me here is Dr. Dennis Charney. He is the Dean of the New York Mount Sinai School of Medicine. Dr. Charney, welcome over to our webcast, and first of all I want to congratulate you. Great progress with the US World Report standing with your Department of Cardiology.
Thank you, and it's a pleasure to be here. As many of you know, the US News and World Report ranks different specialties and hospitals. It also ranks medical schools. And this year we found out that Mount Sinai Heart is ranked within the top 10 cardiac programs in the United States, which we're very proud of. We expect to continue to rise because we think we're as good as anybody in the world in providing great care, both cardiology care and cardiothoracic surgery. So we're very proud.
Congratulations, and I am sure the progress will continue. Dr. Charney, tell us about what do you feel about this program and our partnership with the American College of Cardiology.
Yeah, we're very proud of this partnership as well. It reflects the commitment of Mount Sinai Heart and Mount Sinai School of Medicine in general to be a first-rank education institution. We view as a key component of our mission not only to provide great clinical care, but to educate the next generation of medical students, of specialists like cardiologists and surgeons. So this fits our mission perfectly, and we're very happy that we've been able to partner with the American College of Cardiology.
Wonderful. What about how is your international research, international programs? We had Dr. Fuster here last time, and he's deeply involved with some of these research and international education endeavors.
Yeah, that's true. The clinical programs offered by Mount Sinai Heart, both the surgical programs, the cardiac cath clinical program, and so forth, represents a destination for patients around the world because we offer the kind of care that very few medical centers can offer, and so patients come here to get the very best care. So that's an important part of our mission, to essentially open our clinical programs to patients from around the world. In addition, because our doctors are such great educators, students, fellows, again, from around the world come here to be educated by Dr. Fuster, Dr. Sharma, Dr. Kinney, Dr. Adams. Many of our doctors are well-renowned and great mentors. So fellows want to come here to be educated, and then they leave, and then they practice medicine in the United States and around the rest of the world, so that the Mount Sinai brand essentially is worldwide.
I congratulate you again and thank you for stopping by. We'll continue to do our best with the educational effort and take your mission forward. On the same note, Samin, congratulations to you. I understand you made some stunning progress again with the New York State Department's statistics with PCI.
Well, I can tell you that what Dr. Charney just said, that Sinai continue to rise in all the charts, and clearly the leadership has a lot to do with Dr. Davis as a CEO and Dr. Charney as the dean, setting the mission, knowing that this Mount Sinai now is in the honor roll in first 14 of the US. Then in the school, actually, school is 18. And cardiology being 10, and interventional cardiology top. Year after years, we have shown that our not only the volume, but it's the safety, lowest complication, and appropriateness. In all those numbers, we do extremely well. And actually, the report just came out yesterday. I mean, getting published actually today. And I'll have a slide made for the next webcast. But basically, Sinai once again, highest volume with the lowest complication of the all and elective cases. So that really gives us double star. Continue our mission that yes, interventional cardiology is a field which is very tough. You can take care of the tough cases, but can do it right. And so I really congratulate all the team of my cath lab, my staff, who has really, and the support by all our referring physicians who sends their complex cases from tri-state area. We actually get at least 100 plus cases which come to us by various interventionists in the tri-state area. So you can imagine the complexity of those cases. Those are left main, calcification, bifurcation, so and so forth, and yet to have the best outcome is really testament to our protocol and the whole system which we have placed in to do those cases in a protocol fashion, and the teamwork.
Samin, I am sure it is teamwork which you have mentioned about. I have personally witnessed both Dr. Fuster and Dr. Charney, and it's clearly everybody's goals and missions properly aligned. In the meantime, I have some very interesting follow-up for you. You know, all this time, the last several months, we've been making great efforts getting the Chinese simulcast in good shape. I recently attended the Great Wall meeting, and I can tell you that the Chinese simulcast is being seen by many more physicians than we are able to estimate. A lot of times these numbers are not accurate because at each of these sessions, dozens and sometimes even 100 of these students sit together. In specific, I want to thank Dr. Muhammad Salim. This is a great story. He's a fellow interventional cardiology fellow from Nairobi, Kenya, who's doing a further training in Anzen Hospital in Beijing, and he provided me these statistics.
Wow. Yep, I mean actually same in India also. I was just there this weekend, that at many centers they put a one screen, and there are at least anywhere from 5 to 20 physicians. So that even we are having this 5,000 the registrant or participant every month, that basically the computer click. The actual people who are watching it, it's much more in the multiples, and more importantly that anybody who comes to the page, their average staying about anywhere, we do the analysis by Ricardo, that anywhere from 32 to 38 minutes when they come on. So that's a great achievement and success of this program.
Excellent, Samin. I'm going to let Dr. Dennis Charney continue with his demanding schedule of the day. Dr. Charney, thank you so much for stopping by, and we'll do our best to keep your vision alive.
I'm very proud of all of you. You do great work.
Thank you so much, sir.
Thank you, Dr. Charney. Thank you.
Anu, very interesting case today using the Impella device. I mention it because that is exactly how the series started 40 months ago.
Yes. Yes.
I remember that was one of the most watched program which we had done.
Absolutely. Yeah, and what I'll do is this, while we are getting this, it's a very complex and angulated case, and you'll see it. So what I'll do while Anu is trying to get ready, I'll go through the case, and then we'll have a chance.
In the meantime, Samin, a very pertinent feedback, both constructive as well as providing us some guidance, comes from your good friend Dr. Vijay Trehan from the Pant Hospital in New Delhi, and Dr. Harinder Bali from Chandigarh PGI, two great institutions in India. They specifically requested, Anu, this is important and useful feedback for you also, that whenever you're doing any of the finer manipulations of the wire, if the camera could be focused, they are very interested in seeing some of this. And this morning I hope that we can demonstrate the setting up and placement of the Impella catheter.
Yep. And also that we should always have picture in picture. There is no question that every case, all throughout, we should have a picture in picture. So that, and then when time comes, we need to focus a little more on the hands we do.
I am very grateful to all this feedback. Please keep sending those. The question line is on, that is at info@ccclivecases.org. And finally, I'd like to welcome the very large group of Russian physicians from Samara, Kazan and St. Petersburg, the groups which are joining us this morning. Welcome to you all.
Fantastic. Now with that note, let's start with our first slide of the case, you come inside. Yeah. So therefore, this is the case. Is the 73-year-old male had presented last month with a STEMI, and he actually had a bypass surgery before, and had a LIMA to LAD and SVG to circumflex with a 3-vessel disease and EF of 30%. He actually had also the arterial graft to D1. So they felt that both circumflex as well as that occluded vein graft to circumflex and radial graft to D1 were the culprit lesion. So had a stent, patient had a jeterolimus eluting stent of resolute integrity, and of course rest is right here, small CVA on good medical therapy, and the angiogram will be able to show now. Come this side. Yeah. Move. Yeah, just 1 second. The camera position a little bit. And this patient had already two vessel interventions, and now here for tortuous right coronary artery, which I'm now going to show with a severe LV dysfunction. EF is about 30% in this patient, so we decided that we are going to use Impella Assist Device. And if we can just show a quick anatomy.
So if you see here, this is the right coronary artery.
It's quite a challenge. You have people from San Francisco would call it the Lombard Street, as tortuous as it gets.
Yeah. So if you see the takeoff, it's inferior, not exactly, it's in between anterior and the real takeoff. And in this situation, always the question comes, what's the kind of guide you are going to select? So whenever it's inferior takeoff, I think the best guide is the no-talk guide, which comes from two companies, where either the Cordis and the Medtronic, two guide. But this is the Cordis guide that you have. If you see that it just sits, it's inferior, facing almost anterior. That's the best guide. You see a lesion at the prox, then it turns around, and you have a 95% lesion in the mid after a big RV branch, and then as it goes down, makes another 245-degree bend. You have a moderate 50% disease. Then you have the distal RCA and bifurcation, and there is no disease in the distal RCA and bifurcation area. And if
very big right coronary,
extremely large right coronary artery, probably
so
a
in this
or something.
You see that proximal and the proximal, the mid, which is the tightest, and further down again disease. So if you
no, although you have a downward takeoff, I may have still thought about an Amplatz.
Okay, this is exactly I took a picture. Here. This exactly I took a picture, because most of the people will think this is Amplatz guide, whether you go with AR2, AL 0.75 or AL1, and that's why I took a picture. No matter what kind of manipulation you do, we cannot engage it. If you see, you can see the ostium of the right coming off. If you can, I'm going to stop right at that here.
And that's a 0.75?
Yeah, this is a AL 0.75.
And we try both AR2 and AL 0.75.
So if you can see where the right coronary is coming off, just at least 5 millimeters away from the tip of where the guide was sitting, for that situation, the other question people will say multi-purpose. No, since it's anterior, it is not a good guide selection for this case.
And it might even dive in, I think.
Yeah,
and
the proximal. So this is the one which we did last time. Again, very tortuous. Radial artery going to the diagonal required a guide liner for getting the stent to the distal portion of this guide, and then we have this. And then we have the LIMA to the LAD, which is patent.
Yeah. Good.
Excellent demonstration, Samin. I know you are ready with your presentations, but the questions are coming here fast and furious. Why not a balloon pump, and why are you using an Impella?
Well, that's a very good point, and I hope I'll go through my data to support one versus the other. And the key is that when do we use Impella versus balloon pump? I think you need some support device. We have shown cases with using balloon pump, so that this case is kind of border, because EF usually we use Impella when EF is 20%. This is EF around 30, and so that in this case you can decide with one versus the other. But we wanted to show the new technique the new device actually just approved by FDA. Many of you who have been in the news might have seen that it used to be Impella recovers LP. Now we have a CP, cardiac power Impella. So basically gives you additional blood flow, which used to be about 2.4, 2.5, and now getting to about 4 liters. So that's one, yes, of the various, I would say that because we always try to show the new and the latest and the greatest, and particularly those who are caused impact our intervention, so that we try to go through this process, and that is one of the important region. And in this case, of course, it makes it appropriate because of extensive disease, as we have said. And this is exactly the point will be today, LV support during high-risk PCI and devices for tough and complex lesion. Now, Anu, are you ready to show?
Samin, am I to understand that the reason you are using the Impella today and not last time for the same patient is because the exceedingly complex RCA?
Yeah, this is a very complex RCA, and you know that this very likely to plicate when we'll put a wire in and may cause a significant deterioration, and just to provide that hemodynamic support for a few seconds or few minutes when we are deploying those multiple stents. Yeah. Okay.
And you also have a swan in there for us to see the impact on the...
Well, usually as a part of the Protect 2 trial, we used it, but clinically if patient's EDP, when they put a catheter into the ventricle, which will do for Impella, and if it's okay, usually we don't put us in swan. They are patient with hemodynamic instability, we definitely put a swan at that time.
Excellent.
Yeah. Okay.
Okay, just to go over the insertion, I think very important is one is how you manage the vascular access for these patients, and our fellows, I have Rajiv Narayan and I have Lakshman Prajapat here, who actually are well trained in getting the vascular access, and the protocol for Sinai is to how you get the access. We always use what is called as a micropuncture kit. You have a 21 gauge needle, and then you have the 0.18 wire, and then you have this dilator which is 2 French, and then you have the introducer which is 4 French. And if you see here, so you go with the needle and you leave this, don't even go with the dilator, just with the dilator you take a picture and make sure that you are in the right place where you can place your per-close. So you will have 2 per-close placed, so we call what is called as a pre-close. This is the technique we use for if you are doing any Impella, or even if you are doing valvuloplasty, we know we are in the right zone. Now, as soon as we did this picture, what we realized that there is a tortuosity, and in that situation we changed our plan, that instead of using the regular sheath that comes with the Impella kit, we had to go with the 14 French long Cook sheath, which will be show that Cook sheath there. But that is the way the fellows are trained how to do this pre-close, very, very important, so that when you take out your sheath, that very easy to do the post-close in this case.
Anu, one of the other thoughts could be that a stiffer wire would have straightened out that tortuosity.
We did that.
And
we did that. It did not. Yeah, okay. Supracore wire, we could have done that. Yeah. But this is a sheath that has now in the patient's body.
Yeah. Now, only problem is that it's not when your dilator is there. When you take the wire out, the sheath will kink.
Absolutely.
So therefore, the long sheath will help. Okay, now keep going because we have a lot of work to show. Now, what are you showing, the new Impella device?
Yeah. Okay. So the Impella device, which we are going to be using today, if you see here, if you can show it, Pablo, move. This is the older one. So the only difference is where your motor is, which is a 14 French compared to this was the 12 French motor. Everything else is the same. This is the 9 French, which is the catheter. And here is what your connection goes, which is very easy. You can use dextrose. You need a dextrose. The reason for dextrose is if you are using any kind of saline, that it can corrode the motor. So you need dextrose, whether it's 5, 10, 50, put some heparin and you connect here. A very easy connection. Very important, you need the connection that you can do fast is if you are going to use it in the cardiogenic shock patients. So the only difference, this was 2.5, this is 4.0, they call it 4.0 CP cardiac power. And the sheath is different. this is not the sheath we use today. This is the sheath that they want, that which they say has two valves inside here, and also what they have done is the introducer is a little different in the sense it goes and it screws in, so that your insertion is very easy. Once you are there, then you just take this out, unscrew it, take it out, and just flush the sheath. And after that, make sure we give your whatever kind of anticoagulation, heparin, Angiomax. Then we make sure your ACT is well above 280 before the impeller goes into the body.
Anu, excellent demonstration, and I'm glad the cameraman has been following the motions of your hands and the fingers. Samin, so physiologically this is a totally different animal, a 4.0 magnitude cardiac output.
That's it. Therefore, this is surgical. You can call it the percutaneous LVAD.
Well, let's hope that this turns out to be the game changer, and also the sheath with the added safety to prevent the bleed back.
Absolutely. Yeah. And I mean, in honesty, that question is, could we do this with a balloon pump or with your impeller recovers 2.5? Yeah, I think so. This case fine. But key is that since it has just introduced, we also wanted to be familiar, and if wanted to see that once it will require in a high risk cases, that how easy and or difficult, and we'll see it now that how easy or difficult it is to do it. So now we have put a JR4 in the ventricle, and we are going with this wire.
Yeah. The sheath size is gone from what to what now?
Yeah, used to be 13, became 14.
That's all.
Yeah.
So with just a small increment in the sheath, you have a 1.5 liter augmentation of the output.
Yeah,
and
exactly.
Actually, when putting a JR, the sheath, even this sheath is kinked.
Right.
It requires little manipulation. So even long sheath.
Okay, now same thing is, can you get this without wire? Yes, they say you can even get this without wire. Because of the tortuosity that we face in this patient's groin, we decided that we will go over the wire. And so same thing, very easy. One thing is very important, make sure your ACT is well above 280, whatever you're using, heparin, Angiomax, before you start going in with this device. And this is called as the glide, which was not a feature, but currently this is a feature. You see this red catheter that will facilitate your wire insertion through this pigtail, and it will come out of the motor in the right spot.
In the past, we used to bend and
yes, that used to be very tricky, just that movement. Look, all these small enhancements, particularly for procedures where you are doing.
So now, so the wire is coming out, and that glide sheath is also coming out. So the wire has come out at the right part of the motor.
Perfect.
Here.
To me, this looks to be the most practical enhancement.
Well, yeah, absolutely. I mean, they are doing the, from their side, they keep changing and keep making it better. Compared to which I always have an issue with a rotational atherectomy, that whatever they made, they have not changed anything since 1996 when they came with the rotor links. Yeah.
Okay, insertion same. You just have to be a little firm when you're going in, but you will see lot of bleeding as you're getting your motor through this sheath, like here. See that? Just go in. You saw that bleed, but not to worry, just keeping, and then you can follow the catheter.
There still will be the kink. The sheath kink will be a trouble. You actually advancing JR was the trouble here at this area. Yeah. You have to pull back the sheath a little bit.
Maybe a slight rotating movement too.
Rotating and pull back. Because now, where the kink is, once you pull back, that kink is taken care.
Right.
Yeah. Let it go or no? Yep. Good. That's it.
So the movement that I did was you pull the wire and the sheath, and you advance your impeller forward.
It's the same thing that when you have a kink in your balloon, when you are advancing because of in a tortuous lesion, so that kink, what you do is you pull back the balloon a little bit.
Now, since it's a short monorail, you start seeing it's separating. Not to worry, go all the way to the apex. Pigtail behaves like a pigtail. Take the wire out. And now you go to the console.
So this,
and you are working at the
Anu, one moment. Now, at this moment, now we can visualize where the Impella has been placed.
Go show the console, please.
You are basically going to use the physiological monitoring to determine the optimal position. Is that correct?
Yeah.
Okay.
You can. Are we showing the console? Can you show the console? Now you can see it.
Excellent. We see that.
Good.
At what level are you at the moment?
Show the fluoroscopy there. You have to see that the motor has to be about 3 centimeters above the aortic valve, if you can see that now. And actually with the console it's very easy. You just need to know English. It is not in Spanish, right? We don't have Spanish console or Chinese console. It will tell you what to do. Yeah. So now see that it is the flow rate is slowly going up.
Right.
And Pablo, our tech, will slowly, I think all you have to do is just keep rotating this. As long as we know the patient is tolerating, you just have to. Other thing is also important, that your EDP of the patient is very important. So it has to be on the higher side. Today his EDP was 18. Even sometimes, suppose you have a patient with a EF of 25 and well diverse, your EDP is 10, 12. You have to be careful of getting a Impella down there. And especially this new catheter with the 4.5 liter suction, it can actually suck the LV. So you have to be very careful in positioning. Little T2, pull back a little bit.
Okay. Now, yeah. So basically the console tells us that whether your position is correct.
Yeah.
And the things will move with your guide catheters.
Yeah,
and
guide
various
catheter movement. As you're doing PCI, you know, things can move, and you know, the tech will keep telling you if there is any movement of this Impella device. But I think it's slowly going up.
3.3 is a good enough augmentation.
And they're saying maximum is 4. You don't have to go to the maximum. I think with this guy, no, actually between 3.5 we are good enough.
Yeah.
Anu, it's bivalirudin as
the bivalirudin, and our ACT was 320.
Excellent.
And very important that good anticoagulation, otherwise they will make a clot on those micro holes, and then you will not get a good augmentation. Now, having said that, while we are getting prepared to perform that complex right coronary artery, let me just quickly go through in next 10 minutes or 5 minutes actually, because rest will be the slides. Just go through this data, because we want to really show the crossing this lesion, how it's going to happen, and so. So clearly, when would you use the LV Assist device and support for high risk PCI? I'm not talking about cardiogenic shock and so. We are talking about patients, elective patients, mildly hemodynamic compromise. That two things have to go. One, LV dysfunction, which I say cutoff being 30, plus has a complex multi-vessel disease and or unprotected left main or last single remaining vessel, particularly the vein graft, because those develop more slow flow, and of course you have some hemodynamic compromise on those cases. We have few devices. IABP, CPS used to use it early times, which we don't use it now, which is kind of a percutaneous your cardiopulmonary bypass. Then tandem heart with the PTVA and Impella Recover LP 2.5, and now we have CP 4.0. And there are a few other investigational devices like hemopump and right and bay. Now, clearly that these are the two, balloon pump and Impella, are being used very commonly, again, infrequently overall, but as far as when you come to the assist device, is the balloon pump and the Impella recovers. Now, recent point with the balloon pump, 3 trials in last 2 years. BCIS for high risk PCI, CRISP MI for large anterior wall MI, and IABP shock 2 in patient with the shock. So these 3 trials, actually I'll just go very quickly. BCIS for the high risk PCI, patient EF less than 30%, high jeopardy score, and single vessel supplying the myocardium and the left vent and left main. They were randomized 300 patients, and basically you can see that in even if you did not plan, in about 12% of cases, you will need insertion of the balloon pump because of complication in high risk cases. Very important, this we need to see. And once you do it, it stays longer, and we know that it is associated with a slightly higher complication. But if we go with the 6-month mortality, with a planned or elective IABP, there was no difference, 7.4 versus 4.6, with a p-value of 0.32. And these are the primary endpoints for the Mackey, 15.2 versus 16.0. absolutely identical. This was a 30-day endpoint, and you can see here. And then 6-month mortality, which I showed you the graph, and individual shown there. They basically showed balloon pump electively in a high-risk patient did not work. Then we went to the second, anterior STEMI, which is the large, at least 2 mm ST elevation in 2 contiguous lead, or 4 mm in the anterior lead, and basically plant PCI, IABP prior to PCI has to be, and then they continue at least for 12 hours, or patients with the standard of care primary PCI. This was the CRISP AMI trial, which was presented last year, and then published. The primary endpoint was the infarct size before discharge on done to be day 2 and 5, and you can see actually balloon pump and PCI had a higher infarct size of trend with a p-value of 0.060. Even the proximal LAD with the TIMI 0 to 1 flow, there was no difference. So basically primary endpoint were failed in the CRISP AMI. Now if you go to the individual endpoints of the 30-day of the death, stroke, and you can see there basically no difference at all. Rather they slightly higher vascular complication with a balloon pump, which we'll expect. Now if you go to the 6 months, there seems to be some trend in favor of balloon pump and PCI, as you can see there, height of the red bar. If you combine death, shock, and new worsening CHF, p-value gets to about 0.03. And that therefore now basically you will say in anterior MI the balloon pump did not work. Now we went to the third level, that what about the shock? Shock has a guideline of class 1C and 1B for ACC and European Society of Cardiology, that cardiogenic shock has a class 1 indication, and that led to the task of IABP shock 2 trial. The patient with a cardiogenic shock, about 600 patients. This is a little complex slide, but just tells you that how from a 750 plus cases, that majority of them were enrolled. IABP plus optimal medical therapy versus no IABP, and of the 301, basically 300 were in the balloon pump group, and 298 in the control group went for primary endpoint analysis. And primary endpoint analysis was 30-day, or if patient remain in the hospital, mortality, and you can see identical. So therefore what we did is that shock trial, remember shock was about 45% 30-day mortality back in 1996. Since then we have a lot of papers which have shown that now we have brought the mortality of the shock around 40%, but that's where we are stagnant and did not make any difference with a balloon pump. And of course these are the various individual endpoints, basically were completely washed. The balloon pump did not make any difference. It goes to the list of various trials of the cardiogenic shock, and balloon pump is on top of it in the bottom. Now those are the balloon pump, shock 1, shock 2, negative. Assist devices of the PTVA and the Impella, there are some data, a small study of 60 patients, you can see using PTVA, although hemodynamic improvement, but again same thing, 45% mortality at 30 days. So PTVA did not make any difference. Then there are some trial, small data about for Impella also, but those are not a randomized. That clearly seems to be that in shock nothing is working. It's kind of good intervention, brings it to 40% mortality at 30 days, and that's where we are stagnant. Then for the Impella point of view, we do have a one good trial, which is PROTECT 2 for the high risk patients, 3 vessel disease with EF of less than 30, or left main with EF of 35. This case will fit into the PROTECT 2 trial because of EF of less than 30 and 3 vessel disease. Impella PCI versus balloon pump PCI, because it was open label, and so the decision was made use more rotational atherectomy in the Impella group, more vein graft intervention we know which are associated with higher complication rates, and these are the 30-day and 90-day major adverse outcome, intention to treat and per protocol. And you can see here very clearly that once you get to 90-day major adverse event per protocol, that was significantly lower in the Impella group compared to the balloon pump group, from 51 down to 40.8. Paper was published last month in Circulation. And these are the individual endpoint, and very importantly what we learned, that using Impella you have a lower repeat revascularization. Very important point, that you are, what does it mean? That Impella allowed the interventionist to do a good intervention without able to do as many vessels possible, so the repeat revascularization was lower compared to other aspects which were not, except that in a rotational atherectomy group they had a higher myocardial infarction. So that was the negative point. But even in that group you have a lower repeat revascularization. So clearly the Impella does help, in reducing the repeat revascularization. Now, therefore, I think these are the guidelines which came earlier last year, late last year, cardiogenic shock and so with the hemodynamic support, but they all have to change now based on the new data of the balloon pump which has incorporated in 2001 with the CRISP AMI and the now the IABP shock 2, and there is no clear cut that LV support that randomized trial has shown to be positive, but we use it. Now, these are the various comparison of LV support devices. I have put it: balloon pump, CPS, tandem heart, Impella in terms of various sheath size, complexity, the duration of support, and the cost, which basically just puts the Impella kind of user friendly and really give it a good support. Now, actually, we have to add a 14 French sheath size with having an Impella CP. And this is my simple algorithm that low risk patient with a complex PCI, good ejection fraction, maybe just use a balloon pump. In a moderate ejection fraction, that you can use a balloon pump in the simple PCI. In a more complex, high syntax score, multi-vessel intervention, extensive revascularization makes sense using Impella. And if it is a less than 20% ejection fraction, well, Impella or some cases PTVA reasonable, like in this particular case, will be in the middle group of 20 to 30% EF. Now, I just quickly go with, we have so many devices for tough complex lesion. People keep asking me, what do we use? So I just put them in overall in a one simple way. That one is that guide wire selection. That workhorse wire, frontline finesse like this tortuosity, extra support like this case, or specialty with the CTO, because these are the various characteristics of the guide wires which we need. And like in this particular case, we need finesse, one-to-one torque. So we are able to advance our devices and wire downstream and then change. And these are the various the devices with the guide wires based on complexity. Our case will come with the angulated tortuous and the heavy support, and you can see here various heavy support wires. To me, one of the biggest heavy support wire is the two wires, buddy wire, and of course we the one very specialty wire which is wiggle basically works with the principle of deflection and can be used in some cases. Now then there are various micro catheters. The Venture micro control, initially it was with St. Jude's and now it's with the Vascular solution. It's tip bends at 90 degrees in complex cases, helps you quite a bit. Fine cross micro catheter and similar various other micro catheters available by various manufacturers. This is with the Terumo, and fine cross has become a routine for us in complex cases like this, because gives you a good support and advance through this tough lesion. Then if you have need extra support, Tornus, which I call it a metal balloon, and the Corsair, which is more pointed. I'll prefer Corsair, you can see on the left side, versus Tornus, which is the blunt tip, which is the torpedo type tapered tip of the Corsair. In a many complex lesions, tortuous lesions, calcific lesions, we use Corsair, and then you can rotate it in a one direction 16 to 20 times, and then of course when you're bringing it out, then you do a counterclockwise. So it's basically clockwise counterclock rotation. A gopher catheter, which is also kind of screw, the exchange catheter, we have used it with limited success, and then you can exchange it. Then lastly, which is very important, is the guide liner. Guide liner is basically mother and child guide catheter. Idea is extend your guide into the vessel without causing the damage, and it comes with the 5, 6, and 7 French, which is one higher sizes, and really helps to extend our guide into the vessel and help you support. And I'm sure all these support catheters we are going to use in this particular case. And now tell us now your quick. Yeah.
So the wire wise, we have this fine cross. Actually, we can use any kind of over the wire. If you don't have a fine cross, you can even use over the wire balloon system. And the wire wise we have selected is a fielder wire, same any kind of a glide wire. Why is a glide wire important? If you see it, very tortuous, and plus 90 to 95% lesion. Do not use your regular workhorse wire in this situation. You have to go with a specialty wire in this case, and ideally in this case, that once your wire goes, hopefully the over the wire catheter or the micro catheter will traverse through the lesion. In that situation, you can then exchange to your heavy body wire, which is either your mailman or even the Grand Slam. Have it ready with you.
Okay. All right. So we make a little quick a small tip curve. We actually make a little more general curve compared to many people. They want to make it a the smaller one, and we are ready to start now, and the guide is 3D RC.
Yeah, 3D RC.
Yeah, 3D RC guide, which sit very nicely.
Seven
Remember,
French,
for
seven
upward
French.
takeoff, it's a 6 French. Keep on.
Okay.
Yeah, upward takeoff. You have the shepherd crook, and many of them works with the AL 0.75, as we mentioned earlier in discussion. But once it is down, there were very little choices, and clearly the 3D RC and shepherd crook. I mean,
so
this
let me get the
or Noto
fine
are
cross
very
closer.
good. Yeah.
How much is the augmentation at this stage?
Okay, good.
Yeah.
Not
Yeah,
too bad.
augmentation. It's a 3.2.
Okay.
And the patient has an EDF now. Therefore, same. You go step by step. Okay, little die.
So we made the first turn.
And this is the most crucial bend. Done.
Which is it
Yeah.
has made.
Yeah. And you see that now that gradually just have made a slow advancement and rotation.
Okay, so at this stage what you can do is hold everything.
Yep.
Okay, anchor your wire, and this has to be one person, the same person who is operating, because if you have any resistance, that's the time you hold. That's one thing, and any resistance, that's the time you also you can decide, ask the patient, take a deep breath. Deep breath is a very important maneuver in many of these tough cases where you want your device to go further. So I'm just advancing. You see now the guide is coming out. So
You
now
hold the
what
guide.
you do is advance the wire. Good.
Absolutely lovely demonstration of the technique.
Advance, keep going. So now you got a U loop, nothing wrong. You are in the distal RCA, no disease. If the wire can go, take the U loop. Usually will not take it.
Once it has crossed, then to me U loop works in your favor. Yeah, let's see if we can get further.
Do we have to get the guide liner?
Yeah, this case I think we'll need a guide liner. Look at this, such an unsteady guide. It's going.
No. So now, wait. Let me get the guide. So now I'm getting the guide further in.
And always in the long cases, see now it's the total occlusion there. You start having little ST elevation, which is we expect, and that use a long sheath. Yeah, it will not go any further.
No?
Wire. Okay, hold the guide. Yeah, good. Which is okay.
Sir, deep breath. Respiro profundo.
Go. Go further. Keep going.
Respiro profundo.
Very good.
Yeah.
Yeah.
See how respiro profundo helped us?
Yeah.
Okay.
Deep breath.
Yeah.
Very, very important. Okay,
Now do nothing, don't do any changes. Quickly take it out and get your grand slam. Yeah. Now the guide is outside, nothing to worry, because the catheter here.
So now you need a stiffer wire now to.
Yeah, that will straighten the vessel. Same thing. You will straighten the vessel. You'll have a lot of pseudo lesions. Not to worry.
Take this wire out. And this is the exchange length grand slam.
You need a 300 grand slam, or
centimeter.
if you have a mailman can do it.
Now only problem is you'll see sometimes that when you are advancing these grand slams and so in a tortuous it will going to push out even if you go very slow. And sometimes you'll have a kink, as we talked earlier, that in those cases that you pull back a little bit and now if this pushes out, which could be possible, then what we're going to do, that we'll put a 2-hour fielder wire side by side. That's the case, that we cannot use the grand slam and you're going to use the 2 fielder wires, buddy wire.
That
So
would
now
be
is the same U loop.
ultimate buddy wire technique.
Yeah, that I say the most important guide support is your buddy wire. Yeah. So now I think we start with this
Guide liner
in this case. Yeah, this is the case. We'll start with the guide liner, then we can advance our rest of the equipment on the guide liner.
You don't think a small low profile balloon catheter?
No,
would
we'll go, but
it'll
stent advancement will be a problem. So just be ready.
Sameen, in the meantime, a couple of other relevant questions.
Okay, we just want to show you what this guideliner or the mother and child catheter is same. This is soft, which is what the guide is going to be, but all this is metal. This again has had some improvement. Used to be some metal here, but right now is no metal, is everything is plastic. You just have to be careful. I mean, they usually recommend go with 7 French for most of the cases, but we go with 6 French. If you are using above 3/0 stent, you just have to be careful when you're advancing the stent at the entry of this guideliner.
Yeah, at the inflow particularly, if it is a 6 French. Yeah. What balloon do we have?
We have a 2.5.
2.5 12 emerge. Okay.
Anu, why did you decide not to use a 7 French guide here?
It's just a choice. I mean,
Yeah.
7 French is a rare thing for us.
But do we have a Noto 7 French? We don't have 3D RCA. We might have it. Yeah. But you know,
So
usually
now,
you know that we are all the lower guide
Right.
type.
No, no,
Yeah.
I mean,
but you're right. Yes, 7 may give little extra support. Yeah.
Now it's the same thing. What you want to do, your guideliner is sitting in the guide, but have your balloon ready. So you go with your balloon, and when you are in the vessel, then you advance your guideliner over the
And then
balloon.
we'll take a 3
Because if you just try to advance the guideliner without any support, everything will come out. Two or 2.5.
It's a 2.5 emerge.
Yeah. Semi-compliant balloon.
Sameen, right time to ask you a question at
of
this
course.
time.
Yep,
the
absolutely.
The question
Go ahead.
asked is, with the augmentation up to 4.0 liters possibly, what additional cases would you use the Impella with?
I would say cardiogenic shock. That's it. No other case.
It was also evident in the very beautiful slide you showed comparing all the devices that
Okay, now I have the balloon, okay, at the second lesion. You will not see any flow there. So what I am going to do is then advance the guideliner. We know there is a proximal disease, but advance the guideliner if we can. If it goes, even if this much is good enough, let's dilate at that area. Are we going to do to the? Are we going to do that further down lesion or no?
We'll go
Okay,
distal.
down.
soft lesion yielded quickly.
Yeah,
Advance the wire a little more.
not going.
Now you're saying that what?
Yeah, the question is, the one of the other striking parts was the cost of the devices is also dramatically different, no?
Yes, absolutely.
So how much pressure does that place you with in the cost constrained environment we have?
Well, I mean that's a very important point, and more importantly, actually, the issue also comes that for the balloon pump there is no additional separate CPT, while we have definitely for we go up here.
I don't know. That's not the lesion.
Yeah, that
Okay, go up here.
yeah, that for the Impella, and so they're considered as a percutaneous LV devices.
Okay, down.
So you have a separate CPT code and separate DRG reimbursement on those cases.
So now we have to make a decision. Are we going to stent the third lesion, which is further down? If that's the case,
As
I
we
mean
need
just
it.
okay. Then you go back.
Okay.
I don't think you need to dilate that area. If we can, same thing. The wire is not making any movement further, and then I would want to get the guideliner as far as possible, if it can go. Deep breath, sir. Respira profundo. I'm just doing some juggling movements.
Yeah.
I think it's not going,
No,
but that's okay.
yeah.
Just accept that.
Yeah, we can do first 2 lesions, and that's will be okay. That we are just dilate with a 3/0 now.
Okay, done. Don't
Yep.
do anything.
Yep.
I'm taking this
Yeah.
out.
Yeah. Good.
The patient has been tolerating these maneuvers quite well.
Yeah.
Well,
Yes,
clearly
some
there is some
as-
ST elevations.
because if you see that, if you see there's already diastasis.
Any role of a bolus of 2B3A here?
Yeah.
Well,
no.
he had a CVA before, although he has recovered now, so that we'll try to see. Now the hemodynamic pressure also, once you put a guideliner, you cannot see much, which is fine.
Very fascinating
take a
question has come, Sameen.
Pull back a little bit, right?
All right.
Okay. Let us just go dilate here. Yep.
Dilate
Yes.
where?
Yes. The both areas, and then put a get resolute 30 20 20. Yeah. Yeah. Yep.
So a
Yeah.
little of
Question?
a little of dissection, a little of no reflow.
Yeah, but that
No,
we
that
expect
could be. Remember, I told you when you have this
spasm
stiff, it could be
wire
pseudo
also?
lesion.
yeah, pseudo lesions. Yeah.
Combination of all of that.
right. We expected that.
Samin, a very intriguing question. Just like you have a
Yeah.
appropriateness criteria for indications,
Yes.
should there be an appropriateness criteria for device use?
Well, actually I can tell you these cases until you make it. Once I go, you can advance a little bit. Yeah. Okay, I'm going up now. Yeah. That once you these cases for reimbursement, they ask you all the criteria that why did you use it? Provide the ejection fraction. Provide the vessels, that 3 vessels were there, or left main was there, or single vessel supplying. So all these things are part of it. Yeah. So otherwise you don't get reimbursement. They say should not be done.
I remember from several years ago getting reimbursement sometimes for the Impella used to be a challenging task. Has that become a little easier now?
Very simple. Actually, not only that, now we have the separate CPT codes for the device, so that has become much easier, simple, hassle-free, and there is a reimbursement for the physicians also, because now they come up with a separate CPT.
Okay, go up.
So it has.
Go up quickly. Nice.
We went.
No, you didn't. We missed the lesion. See that?
Okay, then we have to pull back a little bit.
Yeah.
Yeah. Therefore, clearly the proximal lesion was covered with our guide liner, so we are going to pull back and dilate that area a little more.
Go up. Let's just stent it. He's having
Yeah.
massive.
Let's get the stent now. 3O first. 3 or 3.5.
3.
It's a large vessel,
Yeah,
but let's do a
3.5.
3O20 first, and then we'll see further. Patient is having chest pain. We can show a little bit of the EKG. What it is, these are the tortuous cases. So you start with the short. You cannot put a long stent. Will not go. So you start with the short.
Take a picture now. If you see anything. Good. Stop.
Will not be able to see anything. Yeah.
Well, this is also going to be challenging without much visualization.
Yeah.
How do you exactly place the stent?
Yep.
How do you position it?
That is always so that clearly
Let's
the
forget
same.
the distal lesion. Let's take care of them.
Proximal and mid we are doing right now. Yeah.
So
That,
good landmarking of where you dilated.
Absolutely.
will
So
be a
don't
good
move the
idea.
camera position. This is the 3O 22 resolute integrity.
And the very nice features of the resolute being how it navigates in tortuosity should be the probably.
Well,
I'm
this will be the
reading
test.
And also the reason to use it. I think.
Well, actually, in this particular case also, another reason was that patient has 2 other stents of the same, and they are doing good.
Excellent.
I always believe that maybe body likes one particular drug coating, and if they remain good, try to use the same later on.
Wonderful, but I've generally been very impressed with its trackability. Let's see how it performs here.
Okay, now one important issue coming out from
The guiding catheter.
is that, same. You want to pull it out again? Yeah, this is the new system. Since they have taken this the metal piece out on the inflow, we actually have few issues in the. Okay, so take the stent out. The way will be, and then we'll go with loading up outside, so that it has a problem to enter through. And I don't know why they made this change. It was so good before, and now many times we have a trouble, particularly the larger stent and longer stents, to get in with this monorail, which is the whole purpose of it.
Okay.
Yeah.
Stent is destroyed.
Huh?
Destroyed.
Okay. Yeah. Where?
Yeah.
No. That's good. Huh?
It is.
Yeah.
Yeah, it was with something like this in mind that I thought you would use a 7 French guide.
Yeah. Get a new one. Good.
No, but if in a 7 French guide, then you're still going to use a
Right,
7
exactly.
French guide liner.
Yeah.
Exactly.
Yeah. So that's not going to help us.
No, but guideline of 7 French will help. That is a bigger lumen.
entry,
Yeah. Yeah. will have a little bit lumen. Now patient is having some chest pain. Yeah, therefore what we started doing now. Huh?
Yeah, leave it. Let's do
Keep
it
it
at
a little
this
outside.
level.
But it's going to bleed right now.
You have the stent?
Yep. Therefore, basically, we should concentrate here. We are going to advance it now. Stent.
No. What?
The stent.
How can you put a San French guideliner?
What stent we have separate? 2.75 22. Give me the 22. Yeah.
Not 275. We may not be able to post dilate. You have 3O?
Yeah, 12. Give us 3 or 12 first.
Why? That is no. We have one.
Okay,
chance.
what do we have? Okay,
Good.
3 or 22. We are going back again.
Your cameraman is doing a much better job. We see the entire and
Very good.
picture in picture is
Beautiful.
is,
Now
awesome.
also, I know some of the, keep it, that reviewers have commented that they could not hear it well in terms of the audio.
No,
but,
no issue whatsoever this time. We've corrected it.
Okay.
Go, keep going.
It
Good. Wire has come back.
Hold it.
Yeah, I'm holding. Yeah. The wire have come back, and you see, it will be a very tough task now. Advance the stent first.
No, you have to hold the wire.
Yep. Good. Okay. Good. Now we get the guideliner. No, the stent has to go again. We can look for a 7 French also. In case necessary, we might have to upgrade everything to 7 French. Bring your the stent, you can see the wire there. There is not much room there. Oh, no. I have to bring the guideliner now.
right.
Wire alone will not go
This is-
right.
yeah. Probably guideliner and repositioning the wire.
Yeah.
There you go.
Good.
So advance the guide. Wire. Now I'm trying to get the, so the stent is at the ostium of the guide. Now let's see if the guideliner will go a little further.
Yeah.
Yeah, good. Now I will advance the guide. Stent. I think we need a shorter stent. Maybe dilate there.
You are dilated with a 3O there with a high pressure. Ask
Let's
him
see if
to
I
deep
can.
breath.
Yeah, respira profundo. See, that's one thing about this.
I'm sure that
Grand Slam wire is, it's not the tip is not as user friendly.
Sameer, nationwide, I'm sure the phrase which interventional cardiologists know the most in Spanish is respira profundo.
Yes.
The only difference being in Miami, we further add
Some die.
por favor, señor.
All right, por favor, señor. We do it in New York also.
Every
go shorter stent?
conceivable challenge had been anticipated, and this is exactly some of the issues which we had talked about, and you see them, and let's
Get
try
12.
to see
Right
how
now
they
get
are
12.
handled.
Right?
I hope
Keep the
thing will go.
guideline. Huh? I think we start with the 12 right now.
Why it's not going? That's the problem. Did we dilate it?
Yeah, I was thinking maybe dilate with the 3O balloon.
Again, we dilated earlier 3O20.
Right. Maybe go a little high pressure or
18.
But,
Yeah. Let's get a balloon once again, because we need to advance the wire a little further also.
Samin,
Other question,
would you
should
even
we go?
put a buddy wire?
Yeah, that's what we are thinking.
Only thing with the 6 and 6 is very difficult.
Right.
Yeah. Yeah.
I think we have to do. Let's go.
Yeah. No, but
Why don't we do our usual? Take this thing out.
Yeah.
And go leave the mailman, fielder wire, and just take the guide liner out. I think it's not helping us here.
Okay.
Right?
Yeah, but let's advance the wire a little bit further.
Get the fielder.
Fielder wire again. So basically looks like the guide liner is not helping here.
Right.
Should help, but in this kind of angulated
I think that is exactly the case. It wasn't completely coaxial, not have to be careful.
But it should be for this purpose. I mean, this is
No, I think when it's down or take off.
Right.
Anterior.
Look, have multiple so this is, we are already up to game plan C.
yes. Yeah. Then let's go a little further. Let's dilate again.
I think there's no flow in the vessel.
Huh?
No flow in the vessel.
No, vessel is because of tortuosity. Yeah. We
And
know
when
that.
the wire
We cannot
came
see
out.
anything. The ST elevation we have it. Yeah. Okay, going again.
Down. I think we didn't dilate that area. That was the problem. Down.
20 atmosphere. So, but I think it goes to just distal area.
Okay, go up here. See?
Okay. Now, 20. Maybe that was the 8.
Yeah. Every time, keep talking. Maybe it will go now.
Huh?
Should we try the 22?
No, we go with the short stent first. Good. Put the guideline a little more. Good.
See, the
Much
problem
more-
also, the proximal lesion was there.
Much more distally with
Yeah.
the guideline.
Yeah,
I
I
think
went
that
in.
was the
That was the problem.
Very good.
it was
Take
the
this balloon out.
entire
That's it.
solution
Yeah,
of the case.
But you saw how I advanced the guide liner over the balloon.
Right.
The balloon stays in the proximal vessel
22
and the
still.
slow movement of the guide liner, don't even try to see. You will have no flow there now.
Yeah. We'll
But
go with
the
the 12 still.
proximal lesion was the one which was not letting the guide liner move forward.
Samin, a quick this thing, if somebody could show us the hemodynamics with the Impella.
Show the. I hope the stent goes.
Yeah. But we are using a short, show the EKGs and so, and this is the case. Remember that,
Why? 22 will go.
no, it will not, will go.
Some
guideline
ST
is here.
elevation.
Okay.
Except if it doesn't go
Okay.
through that, then we
Yeah,
are in
that's
trouble.
the problem. Yeah. Huh?
Excellent demonstration.
So we are going with the 22 once again. And see, this is the case. Really, Impella is paying off its thing.
22, what happened? You threw out the 22? 22, yeah.
Dr. Alexander Nkani has suggested you could stent the proximal RCA to pave the way and then pass
Absolutely.
the guide liner
Yep.
through the
We
stent.
just talked about that if need to be, although right now the guide liner, see the wire is coming back.
Yeah,
But
guide liner is way further where the lesion is.
yeah, initially, if the guide liner was not going, that was our plan, that you put a proximal stent. But right now, once you go there, get a wire a little bit more.
Well, this was his question. His comment
Let
is
go.
even more useful. He said this is an excellent case. Exactly the kind we want to show
Yep.
how to deal with all the anticipated issues.
Show me where the thing is.
Where do you want to see?
At the guide entry.
Now, just
Yeah,
for
yeah,
some of
you have
you
it there.
who are watching the
1
case
o'clock.
live, to let you know
Good.
that we will
Vantage.
continue with this extended
Okay, now we are
transmission.
getting our stent through the guide liner, going forward, no problem. Okay, here. Yeah, we
That's
got
exactly
it
where it
exactly
needed
where
to
we
support
wanted.
you.
And this time I will try to see if I can advance the wire, which is doing no help to me. Okay.
You seem to be
you want
far
to see some
enough
dye?
there.
Yeah.
Probably won't see anything with the dye though.
No,
but
no, we
now
see,
you
we
do.
see. Good,
You do
good.
very nicely.
Dude, do we take care of the distal?
Yeah, another 2 or 3 millimeters maybe.
No, no, no,
Yes.
no. That is you need a short stand.
You advance the wire? That we can decide later.
It looks bad
but
now.
do you want to pull back? Yeah.
Everything
Can you
is
go
in-
further? Advance the wire a little bit, what happens?
I don't know. You want me to try with the stand further?
Yeah, that's fine.
We
If
didn't
you
dilate
can put
it.
advance, which is
There
fine.
you go. You
That's
advance.
good. Yeah, good. We are at that distal lesion.
Yeah. Okay. We're going
Okay,
up?
die. Good.
Yep.
Everybody happy?
Yeah.
Very happy.
Good. Go up. You see now?
But you need to
We
advance the
are
wire a little bit.
you are not moving. So wire is not going. We are at that area. You know, you are in the soft portion. We know it. You can go up with the
14.
stent.
Yeah.
Yeah.
And
You
that
can go up with the stent, but the same, you know.
3022
12, 14.
resolute, is that
Yes.
what it is? Okay.
What I'm saying is, if at this stage we are trying to see advance the wire, do some other maneuver, everything may come out. So just take the advantage. We know it's at the tip of the wire, but everything is in good position. Just
Advance your the guide liner further, and we get another long stent, same 3022 or so. No, guide. Will be okay. Good. Let's come out.
I'm coming out with the balloon. You want to take a picture so we know we are okay?
Anu,
come out with this.
excellent,
picture.
excellent demonstration of the catheter, and here we
Good.
go.
Okay.
Same view, distally looking good.
Yep.
Good.
The mid is dissection, which is good. People get very much worried about the dissection. I said that's what we wanted.
22.
Yeah.
And proximally you want to put a 3, 5, 14, right? You have a 14.
Yeah. Okay, give us that now.
Samin and Anu, more questions. How
Yeah.
much is your mean duration of use for the Impella? How long are you leaving it in place for?
Yeah, very important point. We actually, all cases in Mount Sinai, when you use for a PCI, we are done it, we are taken out at end of the procedure.
And
So
the removal technique is by how?
Yeah,
Closure.
we'll show you at the end of the case.
No, but
Remote.
basically just
Yeah, same.
pull it
Take
out and the post close.
Since we have the pre-close in place, you could just
So
post-close.
those two sutures.
So with the amount of structural heart disease and TAVI procedures you are doing, this is a piece of cake.
That's true. Particularly that's a 18, or now we actually have done few of the Edward Sapien percutaneously with a 24 French with the two pre-closes. Negative.
So has the use of Impella now become so prevalent that you don't, previously we used to get echoes to see the LV function and the aortic valve, probably no need?
The same issue again. Good. Vented. I'm sorry, say it again. But
Now, I just I had some trouble in getting same at the entry of the guide liner. Very important, before you come out, just make sure your stent is on the balloon, that it's not stripped.
All right, and this
no, I'm
point
sorry.
you-
What was the question? You said echo.
Many, when the Impella was started, there was always concern you had to rule out
LV thrombus. No,
LV
we still do.
You still do.
Yeah,
it,
we
okay.
still do. Yeah, because the LV thrombus, particularly if there is no. Yeah. Particularly the patients which have a severe LV dysfunction with the apical hypo or anterior wall MI, definitely in those cases you will like to do. We always try to rule out LV thrombus. Yes.
This is Dr. Satoda, who frequently communicates with us, asking us, can we use any anchor balloon technique in this case to advance the inner catheter?
Well, I can tell you that there will be nobody bigger anchor balloon compared to this guide liner. Yeah, and having the, of course, guide liner has to come out for the anchor, and we actually need a little bit more
Yeah, I saw you advance the wire there.
Yeah. Tell him to take a deep breath. Respire profundo. Yeah.
I think that has.
Okay. Good. Guide, everything is coming out.
Let's give some dye, see where we are.
No, we'll not be able to see anything right now.
We will.
Okay. We'll die. Yeah. You need few more millimeter.
Yes, just almost there, and you look to be overlapped there.
No.
No, still a little bit further.
Okay, respira profundo.
Good. I think we go up here.
Yeah.
Good. Okay.
Go. See that
Need to go.
problem is that the stent is distorted.
Yeah, right now we have to go.
Come out.
What
Came
happened? Stent broke. Balloon ruptured.
Because of that crack. Down. Everything came out.
Bring your guide up. Good. Yeah. One more. 1 second. We can have our balloon.
No, doesn't
No.
look to have ruptured. Looks okay.
Yeah.
I think this is that movement getting it through the guide liner.
Okay.
Right.
Now in this situation, advance your wire, advance your guide liner. Yeah. Good. That's good. One wire go no further. Advance the guide liner now.
What I would do is advance the balloon first if it goes, and then get your guide liner over that.
I think the edge dissection has not been covered.
Yeah. Get us the 12 before we do anything. Don't even look. Get the 12 stent, right?
Yeah, good. Let's take it out. Yeah, good. We have it here. We have it. Good. Let's take this out.
Very instructive, Anu, how you've secured the guide liner
Yeah.
distally. To
What we are saying is same, that other stent was not
not distally
at the,
enough,
yeah,
right?
and we
you
know
need
with the
to-
distal part we did not cover.
I
So-
can tell you, I think this is the most instructional part of the case at this moment to have secured the guide liner.
Yeah, in the place, and then same, you don't do anything, your balloon stays there, get the guide. So
Right.
that what also very important, if you already have a proximal stent, trying to get the guide liner through the stent, you can destroy the stent that you just placed. So this is the movement you have to do, that you leave the balloon, on the deflated balloon, advance the guide liner, you are distal to the stent, your pressure, if you show the pressure now, what it is. It's damped, don't worry, just get your next stent quickly in, if it goes. You're showing the pressure? Good.
That's okay. You have to just advance this.
This goes.
Yeah. Goes in. Same thing. This guide liner is giving a lot of trouble going entry. Good.
All right, there you go. I think quite easily that should
So now
cover
you don't
the
need to
distal-
see at all.
Yeah.
See that?
Yeah.
Put the guide
Now
liner.
I will pull the guide liner out a little bit. Okay.
Okay.
You are
Pull
good.
back 1 millimeter.
Show some dye.
Oh, you want dye?
Distally we are
Okay, we'll
covered
dye.
or no? Distally you are covered.
Yeah. I'll cover
Yeah.
it. Yeah.
Good.
Okay.
Good. Go up.
We still need a proximal.
Right, but
Down.
I think compared to distally, the proximal will be just more of a positioning challenge. This
Pull
was,
back
I
2
think, the real.
Yep.
Go up.
Yeah, we have what we have 3.5. I can tell you, the Resolute has have proven,
Right.
despite complexities and so this tortuosity. I mean, if any stent has to go to the test of time, I mean, this is it.
Exceptional
Yeah.
trackability and
Done?
Yeah, we'll do proximal now.
Samin,
No,
give me
guideline
your sincere feedback
take a
here.
picture.
How would this patient have been doing without a support device?
Big trouble.
Okay, so
There's no question. Even there now
You've seen
ST
the
just
ST,
finally
yeah.
settled down. You saw even augmented blood pressure was 90. So this is the case. Without it, I'm sure we'll be doing a little cardioversion or a little CPR.
Anu, excellent stent selection and sizing.
Yep, we show the last one and then we quit. I know we have gone almost 30 minutes over, but I'm sure everybody wants to see.
Branches.
Yeah.
2 RV branches are gone.
Right, they are, and which is still the patient
Proximal,
is
you want to put
hemodynamically.
what?
3.528 or something
Knowing
long.
that the guideliner is giving us trouble, 3.5 may have trouble.
Right. So 3.0 and then, but
3.5 may not go.
well,
3.5 may not go through the 6 French guideliner.
Let's give it one try.
Okay.
Right? Because we have it, otherwise you want to take the guideliner out and put a
yeah,
proximal?
that's what I was thinking. What if you
No.
you want to keep it there? Okay.
Please.
Yeah, because it will even,
I'm telling, yeah.
it will be a very tough one, but if we get this.
We have been there.
Actually, Anu did this, that arterial graft to D1, and when I came back from India, she said that it's a very good case for the symposium. I said, well, it's are you sure you want to do it? It's the tough of the toughest. And this is what we want to do anyway, because people are asking, been to various centers, he said, yes, you have taught us everything about the rotational atherectomy and so on and so forth. Show us some of the complex tortuous thrombotic cases and so. And as soon as I saw it, I told Anu that, this is it. Good, you're going up. That's fine.
Good, go up.
I said, this will be the ultimate case for this kind. So this is the 3.5.
Yeah.
Is this the resolute again?
3.15 resolute integrity.
Do we need to post dilate that?
Yeah, and then we can do that later. Yeah,
Okay.
Yeah, we can take the 3.5 high pressure balloon that we will need. We always do a 2 inflations because one, the stent expands with the resistance of the plaque. Second, more spherical inflation, expansion. We will come back in the guide and let's take a picture.
Come here, clean this area.
I mean, in 1992, I watched Jean Fajadet and Jean Marco use these techniques, and I have followed exactly the 2-step dilatation.
Yeah.
First gets rid of opens the stent, and the second is for the apposition. So excellent case demonstration so far. It's clearly evident by the quality and the number of the questions coming our way.
Beautiful.
Everything looks wonderful there.
You post dilate. Yeah, take this one out. Guideline. Take the guideline
And
out.
I think it's going to look spectacular with the use of some nitroglycerin.
Yeah, we'll finish it later. Huh? The 3.512 is good. Yeah.
So now the question comes is how are we going to do the Impella? Of course, what is the support? We have 3.5. So when actually in this case actually STs have come down, is okay, no pain.
Look at the EKGs now, and pressure is good.
And you did not use any GP2B3A.
Yeah, that we try to avoid.
Because of the reasons you cited.
Yeah, because patient has an old CV about 4 years ago.
Okay.
And yeah, good.
No, patient okay.
Yeah.
Good, clean
No.
it.
Yeah. What are we showing on that? And we can just have to post dilate. You look at this one. This is where we were and what we are. This is a superb, was very challenging case, but that is what we wanted to show, and we'll just post dilate. Now, I want to show what's the plan on that side is.
Yeah, so I think 3.5 when you are ready, like here we are just going to post dilate. We don't need any more support at this time. You'll tell your technician that's it, we are done. They will slowly over 10 minutes they will gradually wind down to almost like 1.5. At that time, the way you remove it, you just come out like you can take it out like you're taking out a pigtail, except when you are coming here at the level of your sheath, it will bleed a lot. So just be careful, and you can just take it out. Once that is done, if you can just show the groin, the fellows have everything ready here. If you see the two
focus a little more on
here,
this, yeah.
You can see here the sutures.
Yeah.
You see it very nicely.
Placed. The
pre-close, yeah.
And this part, as we do all this, and the most crucial part of the groin closure is done by our fellows in Mount Sinai. As soon as they come in the first 2 weeks, they all get certified in using pre-close and post-close. So both for our complex this kind of cases, valvuloplasties, or right now the tower procedures, fellows are the one who do the pre-close, post-close, and handle the groin.
Excellent. In the meantime, a very important information. This is for our sister presentation, the Peripheral Interventions webcast. That's going to be on October 31st as opposed to the previously announced date of October the 24th. Samin, how is Dr. Krishnan doing with that? That's also gaining traction?
Yep, and our goal will be that we do HCC partnership by January.
Wonderful.
Yep.
And
good. Now we just can come to the last. We'll just dilate here.
Yes,
Everybody has seen the last picture. Just show once again.
We would love to see the. I bet you with the post dilatation, some nitroglycerin. This is
but
going to
everything
be
else looking fantastic. Look at the EKG.
What we are going
good
to
blood
do is
pressure, no
post-dilate.
chest pain.
Yeah.
That we can do offline. I think the purpose has been done. Show the last picture. Playing. Good. Yeah, that's where we are. And I'll just sum it up because of we have taken very good time. That is the take-home message. If we can get the slide, the last one. Very simple. The 3 recent trials of IABP in various clinical settings have been negative. You know, so much so we always loved balloon pump. Now, of the 420, just give you some data. Of the 420 PCI cases we do in our lab every month, we use about 20-25 balloon pump. So balloon pump comes out to be about like 4 or 5%, and we use 2 Impella. So basically very small. You can say the ratio. Now you say, well, could you use more Impella and so, but clearly keep it for selected cases where it is really needed. The Impella LV support device seems to provide sustained complete revascularization with lower TLRF follow-up, but again have not shown to improve any of the complications, the death, CVA, and so. But at least not a higher vascular complication. So therefore, this field of the LV support, in my opinion, is still lot of anecdotal, lot of personal feeling, and it just basically that what you are good at it. This case, I can tell you that if that RCA being closed for almost 15-20 minutes during this complex intervention, if you would not have a support device, this will never be part of any trial. That patient will develop cardiac arrest, and you have to do a ventricular fibrillation, the shock, and CPR. Lastly, the innovation in guide wires and the delivery devices has enhanced the success of PCI in complex and tough lesions and reduced the procedural complication, like exactly this case. So this is the kind of case where all these devices made this possible. Balloon anchor technique, and so we have tried many times, but guide liner, in my opinion, goes beyond any of those balloon anchor technique if you can use it, and many places out of the country may not be available. They may need a little bit of modification, but this is a fantastic device for this purpose. With that note, we complete our today's webcast, and I think we just Anu can say some last word on this.
No, I think I think the only thing is the tip is the same when you do this Tortuous RCA. When you look at them, guide selection which we went over. I mean, if the guide liner is not available, how would you have done this? It would be 2-wire technique. You use your either a Grand Slam or a Mailman. Then you use your other either you can use your workhorse wire or Fielder, Whisper, any wire that you have, and work on that floppy wire to get your pre-dilatation is a key, and then get your stents down there. But I think every step that how you do has to be that fine movements with the guide liner, wire, balloon, and the device. Step by step we just have to go over, and most important thing is we knew that we expect that the vessel would close as soon as we put our Grand Slam wire. So in that situation you have your angiogram, which is already which this is the way it is supposed to look. So quickly pre-dilate, do your stent, and come out, so the movements are faster. Here we went little slow because we had to show the technique, and when there is ST elevation, keep doing the procedure so that you are able to deliver your device and come out faster.
Anu, I want to congratulate you on your superb skills, your unflappable demeanor through an exceedingly complex case, your wonderful fellows. Samin, great review. I truly believe that today's case is illustrative of something else which we have tried to do. You understand that what you had discussed during the case, what you anticipated, the support LV devices, the support wires and the catheters, and everything else which you discussed in a very beautiful presentation has been demonstrated in the use of this case. So to me, not only are the fellows and the people watching the case going to learn theoretically about the scientific use of those devices, but in a perfect practical illustration of exactly those same catheters in a complex case. A great case, wonderful demonstration, excellent. I think this is a show of clap for your wonderful staff for today.
And before the clap, I just want to say exactly what you said. I ask all my fellows in the complex case, what do you want to do? And if you have that plan, even deviation from the plan, people say, well, this happened, that happened. I said, no, then your plan was not correct. So once to have a clear plan, the deviation even from the plan is, in my opinion, like procedural failure, which happens only 1 or 2%. So clearly, strategy correct, this is what you are going to face, and you plan accordingly. You say, well, I want to try this. So that's again -5. I come and they say, oh, this is a tortuous lesion. I'm going to use a rota, the run through or some. I said, that's it, -5. It's not try, where you know exactly what's going to work. So they had to have a clear-cut plan, even deviation of the plan, which is nothing surprisingly happened. I tell everybody, PCI, performance of PCI in this day and age is 100% predictable. It always, we learned that because of the devices and so that you clearly have to have clear plan what you want to do and exactly follow that. With that note, as you said, that definitely this needs a big clap of Mount Sinai. Okay.
Samin,
thank you.
Anu, great case. I also want to thank Dr. Charney for sharing his vision. Congratulations to Mount Sinai for the accolades recently gathered, and we'll see you back November 20th for session number 41. Till then, goodbye.